called Geofrey a lab technologist by profession, but also master student finalist. And this paper has been accepted as my dissertation. I'm also pursuing Masters of Molecular Biology and Biotechnology from Ulu University, and currently I work at Uganda Cancer Institute as the lab manager, Ulu Regional Center. I got interested in this topic, and I chose to do as my research for masters because I worked in both private, the government, and also at the lower health center. So I found it very critical for us to discuss and to see how best we can improve. Therefore, my title is Rationing of Healthcare Services and Medical Supplies, the Internal Medicine Board or Mulago National Referral Hospital. Okay. Rationing is a measure to ensure that healthcare services are delivered fairly and equitably, and this involves prioritizing individuals who need the most intervention. In that context, it involves the frontliners in one way or the other to hold to restrict the access to some of these valuable potential to other people so that others can access. We know very well that healthcare is a global problem, and in our low and middle income countries, the shortage of medicines, trained staff, long waiting times often lead to substandard treatment of the individual. And in that context, medical doctors make decisions by rationing services through deletion where they prescribe treatment or alternative when there's a proper intervention because probably it's not there or an individual or patient cannot access. Others through denial where we say restricting, others deterring where you advise the patient to go and access maybe a diagnosis from outside or to buy drugs from outside, which is a common practice, especially in our setting here. Therefore, in that context, shifting the life and death decision to frontline providers due to inadequate resources really cause more injury. Resource allocation, as I mentioned, remains a significant challenge for healthcare system globally. In Uganda specifically, our sector is really critical and underfunded with only 5.1% of national budget allocated in that financial year, according to World Health Organization report. This financial year which we are moving in, Mulago as a national referral hospital has been allocated 17.756 billion. And in their budget, they needed 101 billion Uganda shilling. And in that situation, it limits the ability to recruit and retain healthcare workers, maintain facilities, and deliver essential services. I would like to put in record that when the ED appeared before the health committee, she eloquently stated that it is in the public domain, where I said, we shall continue sending our patients out to access drugs and diagnosis from outside because we don't have the capacity if they don't increase the budget of funding. Now, in that situation, the frontliners, now they have to decide who receive various levels of care. They have to decide on how to balance those care with ethical values, efficiency, and transparency, and with the absence of clear guidance on the rationing of healthcare services, where it has been spotted in some of the normative rules like the Constitution of Uganda, where they said equal access to health care. The Patient Charter of 2019, they said there should be given equal access to health care to patients. And even Uganda National Clinical Guideline in its preamble talked about the precise care and also accessible care. There is no clear guideline, a standalone guideline, which gives a potential courage to a frontliner to make a decision when making decision on providing care to patients. So in that context, it really gives a moral concerns. In my study, the significance of this study would help to identify the most effective strategies for resource allocation, ensuring that decisions are fair, transparent, and evidence-based. Also, from this study, if we develop a new guideline specifically for rationing, it would empower the medical doctors to prioritize based on medical necessity, patient outcome, and cost effectiveness with confidence. It also gives them potential to identify the gaps in healthcare access and outcomes, allowing for more targeted intervention to address the existing inequity. The objectives of the study are to assess the rationing of healthcare services and medical supplies, but specifically the specific objective was to see the extent of rationing, experiences of medical doctors, and the strategies they use besides the lack of the guidelines and others. Methodology, it was a cross-sectional study design conducted between October and December 2024, and it was conducted at internal medicine wards, which is Ward 4A, 4B, Ward 11, and TB of National Referral Hospitals. The study populations are medical doctors who are employed or permanent employment by the Ministry of Health attached to Mulago National Referral Hospital. Sample size determination, 15, my saturation reached at 13, but for continuity and consistency, we increased by 2, and the saturation reached at 15. During the inclusion criteria, we selected those doctors who were already employed or permanent by the Ministry of Health in Mulago, and we look for their access and the convenience time. That's why I used the convenience method. The data collection was in-depth interview, and the thematic analysis was used to get the insights of the information on rationing. Those are the ethical issues with ethical consideration. My results, there were 8 female doctors and 7 male doctors. The 8 brackets were between 35 above 40, but most of them are between 31 to 35. Their level of education, most of them, they had masters, which are currently, we call them associate consultants, and we have one with a PhD and 3 bachelor holders. Their working experience, they are between 5 years, 6 followed by 6 to 10, and 16 and above, there are only 3. In the results, when we looked at the extent of rationing of healthcare services, we looked at their understanding of rationing healthcare services. Most of them, they really know, they are knowledgeable about the rationing of healthcare services. Therefore, one of the quotes, in my understanding, healthcare rationing involves either failing to provide a service to a patient or limiting access to medical care for a specific population, not due to intent, but because the resources are unavailable. Thank you. The finding shows that most of the common method of rationing were through dilution and deterrence, which I already explained. And one of the quotes are saying, the main challenge is finding effective alternatives to costly diagnostic tests. For instance, there are cases where I would prefer to conduct a CT scan of the chest for a patient. But if they cannot afford it, I have to resort to using an X-ray, which may not provide the best. On the experiences, their lived experiences, the finding shows that they experience those rationing issues every day. And one of the quotes says, happens every day. So for example, right now we have a patient in the ward, is very breathless and has low BP and need to be in an ICU. However, it cannot happen because of the nature of the TB. Therefore, we need a different ICU specifically for TB patients, which has not been arranged. The strategies used, one of the things which is a common practice for medical doctors is triaging. I've been triaging the patients, and they also involve the different stakeholders in addressing the rationing challenges, where also they included either the patient or patient caretakers. And one of the quotes by a participant saying, they practice patient-centered care. I explain the symptoms and the disease to the patient. I explore everything. I provide available treatment options, align what we can do and what we cannot do. Then the patients make a decision based on his or our wishes and priorities. In the discussions, there were some agreed previous finding with our findings, or my finding, where they said that participants are knowledgeable on the rationing healthcare services. The study done in 2023 also agreed with it, and the implication, it improves the patient outcomes if the rationing is properly. The common rationing methods still the same. Physicians choose not to order a confirming diagnostic test on an additional day or an additional day in the hospital. So they always discharge patients when they're not ready to be discharged. And the implication here is give substandard treatment to patient and denial of care that might offer some benefits to the patient. I'd like to jump to the last one. Medical doctors make decisions based on the urgency of the situation in the first come, first served decision. However, there's a study done in 2011 in Uganda here which disagreed with that. Because if you consider first come, first served, then it would favor the wealthy individual who can travel quickly using the vehicle and other means, and they wait in the line, leaving these poor people who have to walk in a long distance. And it is susceptible to corruption because people may bribe a way to be the first in the line or whatever mean. In my conclusion, rationing is viewed negatively due to its association with scarcity, deprivation with society's beliefs. Significant pressure is put on healthcare authorities to provide equitable and fair healthcare services to the population, which eventually take us to moral injury. Rationing is indispensable. Society must try to allocate the available healthcare resources efficiently and equitably. Therefore, my recommendation, there is need to develop specific guidelines for systematic rationing of healthcare services, not based on or merged into many normative rules which we have in the country. Healthcare scarcity should not be managed, but rather be eliminated if it is possible. We should invest more in it since health is essential. As I go down, this has been an acknowledgement. One thing the audience will take note of is in my last conclusion, which we say, if possible, healthcare scarcity should not be managed, but rather be eliminated. And we should invest more in it since health is an essential. Thank you so much.
Thank you so much.